Today, I'm excited to welcome Virna Little, a nationally recognized leader in mental health, behavioral health innovation, and overdose prevention. Virna has spent her career working at the intersection of clinical care, public health, and scalable systems, helping organizations move from intention to real measurable outcomes. Her work focuses on improving access, saving lives, and building sustainable models that actually work in the real world. Virna, I'm so glad to have you here today.
Well, I'm thrilled to be here. It's a pleasure.
Very good. To start us off, can you tell us about your work and the problem you were determined to solve?
Thank you. Yes, I think these days one of the things that I'm very passionate about is building the ability to scale behavioral health services to really expand access and to really allow for opportunity around outcomes and to build and support measurement based care. Unfortunately, we are also losing way too many people to overdose and suicide, and we know those deaths are preventable. So I started an organization called Concert Health, which is a behavioral health medical group almost 9 years ago now. And we focus on partnering with primary care and healthcare organizations, optimizing the collaborative care model. And that really brings access to primary care providers to evidence based behavioral health treatment and brings behavioral health treatment to a lot of communities where there was no access previously. 4.5 years ago, I started an organization called Zero Overdose, and Zero Overdose works really hard to bring overdose safety planning into the hands of individuals who need it. We know that reversal medications like Narcan have done wonders in reducing overdose events and deaths, but we actually try to be upstream and say we don't even want that overdose event to happen. We want to talk to people about being stay safe and staying safe and preventing that overdose event to begin with. That work also has led us to do something called Spire, where we're working across electronic health records and technology organizations to optimize technology to support suicide and overdose prevention. So, a little bit about trying to again expand access to quality behavioral health services.
That's fantastic. And most companies take quite a while to ramp up. Did you feel like your ramp up phase went pretty quick because there's such a need for this?
So I think for Concert Health, one of the things that was tremendously helpful was CMS passing the codes in 2017 to support collaborative care, because we all know that if you can put some money, then we can hopefully expand access. So that was incredibly helpful. And now there's some federal opportunities as well with advanced primary care and with the new access initiative that CMS announced last week. For some of the overdose work, I think the opioid settlement grants have been helpful, but I do think we have not been able to really bring primary prevention onto the ground floor of overdose prevention. And so we're still really depending on some harm reduction strategies, primary prevention, reversal medications, but we don't have really broad implementation or broad systemic ways to implement overdose safety planning and really prevent those overdose events. And we do know that overdose safety planning works. We have data that says it reduces overdose events. And yet, overdose safety planning is not required in 49 of 50 states in treatment services. And so we know that that's a significant gap, and we have our work cut out for us. So it is going to be hard to get everybody moving forward, especially now when things are a little unsure for some of the funding sources.
Looking back, what moments or experiences most shape your path into leadership into mental health and behavior health?
I think I do a lot more public health than I thought I ever would. So, really thinking about it was very nice to solve problems and to train people sort of in my program or in an organization. But then to think, how do we actually change individuals' experience on a much broader scale? And so, thinking about ways to do that. So, Concert Health serves 21 states now. We're really working around zero overdose to be able to be mainstream. And so I think it's for me is how could I lead efforts that were really gonna bring long-term large change to populations, to states, to individuals, because many individuals do not get access to evidence based behavioral health treatment, whether it's behavioral health or substance misuse. It doesn't matter. It's still not available or accessible to many in this country.
Leadership in healthcare comes with unique pressure. How would you describe your leadership style today and how has it evolved over time?
I think you have to evolve over time. I always like to think about it like a hockey game and to be able to say, in this hockey game, where is the puck going to be in 6 months, right? What is that going to look like? And so, always trying to be strategic and understand what is happening now and where I need to sort of bring my organization and where I need to look for funding that sort of continues to change. So, I would say you always have to evolve and you always have to try to think ahead. I would say one of the pieces for me that I really enjoy, I love being in the behavioral health space. I love being a social worker. I love being a psychologist. It has been a wonderful career for me. And it's heartbreaking how many people are leaving the field, or how many people, I looked at data the other day, how many people complete their degree and never complete their hours or never get independent licensure. Like, that's heartbreaking. And so for me, how do we inspire those folks to stay in the field? How do we inspire to love it as much as those of us that have been in the field for a while? And so that for me is a really big driver. And how do we try to support them? How do we train them? And how do we continue to train them so that they can take the next step to really build out evidence based treatment, to expand access, and to then further encourage others to go and stay in the field?
Right, right. That's really good. What do you think if you were to try to guess, why do you think that they're leaving or not staying or not starting?
I think this is probably going to be a little bit of an unpopular opinion, but I actually think the schools, and this is not just me, I hear this from leaders in the space, that the schools are not preparing them. They are not focusing, as an example, on diagnosing. They're not focusing as much on evidence based treatments. And then what happens is they graduate, they get put in a community mental health center. They're asked to diagnose and treat people, to have a full caseload almost right out of the gate. And what happens is they're not prepared. And I think that becomes then not a good experience for them. And I think there's a big disconnect from what the schools are teaching and what they're doing versus what they're going to experience, especially now when our community based mental health centers and our community based organizations are under so much pressure, and the acuity of people that they're seeing is much higher. And I think that absolutely has to be changed. If we don't change what's happening in that educational experience to truly prepare people, we're not going to change what happens when they come out.
Very good. I appreciate that perspective very much. Where do you primarily get funding from?
So, fortunately, there has been some changes that really support collaborative care. However, the funding for collaborative care continues to not be enough to support the team that you need to provide it. You know, you need the care manager, you need the psychiatric consultant, you need a registry. And so we're continuing to do a lot of advocacy to say, listen, we have really good outcomes. We have total cost of care outcomes. We have clinical outcomes. We need to be able to put some dollars in so that we can continue to expand and optimize collaborative care. And that ultimately will help increase access and improve some outcomes nationally. It has been incredibly difficult for doing some of the substance misuse work because I think there are a lot of organizations that have lost funding and a lot of the regulations are changing. And the community, the certified community behavioral health centers are trying to find their way in many places. And we continue to do a lot of training and a lot of training contracts. We've done some work recently where we've been the first in the country to develop a joint suicide and overdose sort of safety planning. Because what happens now is if you were a clinician and you were sitting in a state and you had someone and they had very high social determinant risk, they were at risk for suicide, they were at risk for overdose, which is not an uncommon experience for many of our frontline providers. Some organizations had them doing two separate safety plans, or crisis plans, and two very different pathways. And so what we did was we actually brought it all together and said, let's understand risk. And if they were all in a race, who would win? And then how do we use a safety plan, and how do we bring the other risks into that one safety plan? And that has been incredible for frontline providers. It's one of our most requested trainings. I've shared it with a couple of states. And that I think we need to do some more work like that so that we can really understand risk and be able to save lives from suicide and overdose.
Very good. And you bring up a good point. So it's state specific. So you end up having to build relationships with leaders in every state.
That is actually one thing that I think makes service delivery and advocacy so difficult. So if you take the collaborative care model, 35 states have put the codes on the Medicaid fee schedule, and it is all over the map in terms of how they've chosen. Not only are the rates different, going from like 60% of Medicare to 120% of Medicare, but the requirements are different. Some need prior authorization, some only let certain people participate, some excluded federally qualified health centers. And so, what it does is it makes it really difficult. And also, if you think even about outcomes or looking at effectiveness, it makes it really difficult. And it's the same with a lot of the substance misuse. A lot of the opioid settlement funds have just funded all kinds of different things. And so it hasn't allowed us to really say, okay, what is actually working across all populations? How could we put some themes in here or some interventions or some activities that we could then say, okay, we have enough to say that this really worked, but there's no real coordination in some of those services. And the regulations are incredibly different in every state for services. And so, it makes it a lot harder.
It would be very nice if we could unify because we're all human and make it like the national just human services so we can find a way to make them cohesive, you know?
It would also be helpful because there's compact licensure out there now for social workers that they're fighting for. And so if I'm a social worker now and I could be licensed in 7 states, but all 7 states have different requirements for supervision. Some I have to have someone that sits in the states, others I don't, others I need this. And then everyone has different regulations around documentation or requirements. That's going to make it much harder. So it's almost like we have this really good idea, but then we need those states to say, how could we actually come together for service delivery so that we could really support workforce?
What geographic areas or markets do you currently serve with your business?
So certainly working with the states that have passed the collaborative care codes to be able to really encourage integrated care and the adoption and optimization of collaborative care for zero overdose and the other initiatives, it's really national. And a lot of times it's working communities that say, hey, we want to adopt overdose safety planning, or we want to do something to reduce our suicide deaths. We want to be able to work with individual states so that we can try to get some broader adoption and support. So it's varied now, but mostly it's national.
Very good. What major industry trends are you seeing right now in mental health overdose prevention that are impacting growth strategies?
I would say a lot is workforce. How are we really developing and training a competent and capable and I'm going to use happy workforce to be able to come in and care for individuals. And I think that to me is probably something that requires a lot more national energy and really focusing on what we need individuals to do and how can we appropriately and adequately train them. I think that is a primary issue. I also think the loss of some of the reversal medications and access to reversal medications, we're going to see an increase in overdoses again. And so it's even more important now to try to get out ahead and make sure that people have safety plans and that we've really built safety plans in to the regulations, requirements, legislation for providers, communities, schools, healthcare, behavioral health.
AI is becoming part of every healthcare conversation. How are you currently using AI or data driven tools, if at all?
So, part of what we're doing in the Spire project is we actually looked particularly at suicide and looked across all of the electronic health records. And it turns out there was not a single electronic health record that actually had all of the components of optimal suicide care. And so that I think wasn't surprising to me, but meant that we have a lot of work to do to try to get technology to support behavioral health services and service delivery. I'm fascinated by some of the AI, particularly around the ability to have a conversation with someone and have it predict the likelihood that they'll engage in care, because then I might do something different. I might schedule them the following day or in 2 weeks or whatever that looks like, or maybe they could complete something online versus maybe not. So I definitely think there's tremendous opportunities there. But I am very cautious about some of the AI for suicide in particular. There've been some difficulties there and some inaccuracies. I do think there are tremendous opportunities to bring technology, particularly regulatory or foundational, so that if we require an electronic health record to have basic suicide prevention, basic suicide safety plans, and overdose safety plans to be an electronic record, we would catapult some of that forward in terms of supporting frontline providers and organizations and saving lives.
Many organizations struggle with lost leads or missed opportunities to engage people earlier. Where do you see the biggest gaps in the system right now?
So one of the things that I see, and many of the states still, I think, are have very antiquated practices, and that is this idea of you must come in and have this intake. And I understand getting foundational information to be able to care for someone, but a lot of the regulations and a lot of the requirements and a lot of how behavioral health gets paid, right, is around services and functions that don't engage patients. It becomes about completing those activities and not engaging the patient. And it's very difficult for frontline people to engage someone when I have to get this 4 pages of information and I have to do this and I have to do this. And I think that we need to change some of those regulations. And I also think paying for behavioral health services in 45-minute increments, or saying that you have to do this before you can get paid for that, is actually not patient centered, and is why the engagement in behavioral health treatment is so low, is because people are so busy jumping through regulatory hoops and payment hoops that they actually can't take a breath and really develop a rapport and provide the care that that patient actually needs when they need it, sort of the right care to the right person at the right time. And I think we need to dramatically change some of those systems.
Do you think there's opportunity for AI to be able to support filling out some of those technical things so that it gets done faster on your behalf in order to allow the clinician to be able to work more with what the patient actually needs at the moment?
So the answer to that is likely yes. I think the accuracy is a little up in the air, but I do actually think the answer to that is yes. I think I would go back to the core question, though, is what do we actually need to know to care for someone, and how could the experience be a little bit more engaging? And how can we change some of the regulatory requirements that put us in the need to even use the AI, right? So it's almost like fixing the existing problem, as instead of going back to say, why do we have this problem, right? And
Yeah.
what can we do so that we don't have the problem?
Almost like you could take every state's regulations, dump them all into an AI, have it sort through all of them, see where the crossover is, and make it more efficient on the regulatory side first, and then collaborate it better and make everybody be able to work directly with the people, which is what the goal is anyway, right?
It's so interesting that you say that, because that's one of the projects that one of my macro students is going to do. And then it would be interesting to say, here's what everyone has in common, right? Here's some of the outliers, and here's what's research best practice. And to put out an article, I'm not sure how many friends that will make me, but sometimes we're not always in the business of making friends, right? but I think it will be interesting. And I don't think anyone has ever done it before. So, stay tuned for that.
Yeah,
But
that's
yeah,
neat.
I've been kind of advocating for some of that. And I think then it would allow us to go back to the payers and to the states and say, wait a minute, so who knows? But it would be an interesting article.
Absolutely. What is currently working really well in your organization that you're especially proud of?
So I think for Concert Health, we have done a really nice job at suicide care. And we have been a leader in suicide care, and we have been a leader in showing that the collaborative care model can appropriately, adequately support people at risk for suicide and get good outcomes. And so I think that's been wonderful. We put some things out about it. And I think many people who die by suicide saw their primary care provider the month of death. They're active in the patient portals. They come to primary care when they're not engaged in other services. And so I think collaborative care has a unique opportunity to identify and then care for those individuals. So I think that's been wonderful. I am super proud of the joint curriculum between suicide and overdose because I think it will not only help save lives, but I think it will really help support frontline individuals who sometimes literally don't know what to do or who have very conflicting requirements. So I think those are some exciting pieces and I'm looking forward to really expanding.
That's fantastic. On the flip side of it, what's frustrating?
I think frustrating is the lack of consistency across states and payers. I think it's still continuing to have payers and states understand about collaborative care and understand that actually the outcomes and the cost savings make it something that they should really be leaning into, particularly in these times. I would say it's also really frustrating because, it took years for suicide safety planning to be mainstream. Like, the research was there, we knew it worked, and it took years. And so when I started Zero Overdose, I said, I don't want to focus on anything else other than just the safety plans. I want to get safety plans into the hands of the people who need them when they need them. And it is really still difficult that it's not a requirement. Like, it's listed as a best practice. SAMHSA said, hey, best practice, but it's just still not a requirement.
Just for someone like me who doesn't completely grasp that, what is a safety plan?
So essentially, for overdose and suicide, what we say is, we don't want you to die. Your life is really important to me. I don't want you to die by suicide. I don't want you to die by overdose. And it is sometimes hard to have a conversation with someone who maybe just is coming out of recovery, right? And they're very excited about their recovery. And you're talking to them about essentially reusing and dying by overdose. But we also know that reuse is part of the process, right? Like, I've been on a diet my whole life. I reuse all the time, right? And so it's part of my path, right? So it's part of a path. And to be able to say, so if you weren't going to die by overdose, what would we need to do? Well, my mom knows what I'm doing anyway, so I won't lock the door so she can get to me. I won't use outside in the car, right? In the wintertime, we're going to figure out something else to do. Or I just had a baby I haven't used in a while. If I use this amount in this way, I will likely die because I don't have the same tolerance, right? So what amount could I use or how could I use it? And again, we're not supporting use, right? We're not supporting or condoning. We're just saying, if that is your path, right? And if that is going to be your experience, we don't want you to die because you can never find recovery if you're dead. And so very practical, very, very practical ways. We don't want you to die by suicide. What could we do to keep you from dying, right? How could we, if we were going to keep you from dying by suicide today, what would we have done with your gun, right? If we were going to keep your gun from being used to help you die by suicide, what would need to happen? And so very, very practical. When I use, I'm going to call the warm line and I'm going to keep them on speakerphone so that when if I stop engaging, they know where I am, they can call for help, right? I'm not going to lock the bathroom door. I'm not going to use in the shed. I'm going to use a lesser amount. And so whatever that looks like, that is what safety planning is. And anyone can do a safety plan. You don't have to be a licensed person. We've taught Meals on Wheels people, community members, parents, school teachers to do safety plans.
Actually, it's just a really good mindset change. I mean, and an awareness for anybody. Like you said, anybody can do it. I mean, making that standardized so that people know what to even look for or little signs to see, and then naturally click into a safety plan mode of just thinking. I think that's great.
And also drawing so a lot of times I will say to people, when you were young and you were taught what to do if you caught on physical fire, right? Like I don't remember when somebody told me to stop, drop, and roll. I don't remember, right?
Right.
But I've known my whole life, even though the likelihood that I'm going to catch on physical fire is pretty low. But nobody ever taught me what to do when I caught on emotional fire. And actually, it's more likely that I'm going to catch on emotional fire. So I tell people, I want you to know what to do if you catch on emotional fire. Here's some things that might work, right? So that safety planning, even if someone don't has a history or has a history a long time ago, here's how we can keep you from dying by suicide. If you catch on emotional fire, here's some things that can help you. And people go, oh yeah, like that makes sense, right? Sure.
That does. That makes sense. And honestly, it is not something that is ever even talked about. But it could be as simple as that and incorporating it into the normal safety things that we do teach. Just awareness of thinking about that. I'm really glad we had this call today because this isn't something that I struggle with and it's not something in my immediate circle. But I bet you now I will start to notice things in other people around me. We just went to the beach and there was a lady there, and now that you're saying that, there was one lady there that I now wish I would have went up and talked to.
And it's important to teach people the language to talk to suicide. I will never forget, I was walking in Newport. They have in Rhode Island along the cliffs. And we passed this guy and I just went, ugh. And I went back and I said to him, I was just passing by and I came back because I'm wondering if you're thinking about dying by suicide. And he said, no, he said, not today. He said, but I have in the past. And I said, you're here alone. Why don't you walk with us to the end of the path? Right. And so it's important to use the language. Ask somebody exactly what you want to know. And I had somebody tell me recently they were driving their kids to soccer practice and someone made a suicidal statement. And we had taught them what we call storage statements, 2 sentences to say when someone tells you they're thinking about suicide. Thank you for telling me you're thinking about suicide. Your life is very important to me. And so that people have the questions to ask and the responses is incredibly important. So I was super glad to be here with you today.
Very good. I really like this. And I'm in agreement with you. Like, I want to lock arms with you because I really agree with you that this needs to get out there. That simple of a message and that important of a message.
Absolutely.
What's the biggest win that stands out to you over the last 5 to 10 years?
I think the adoption of the collaborative care codes federally by CMS, and then more recently, the inclusion of the collaborative care codes with advanced primary care, and including in that guidance the safety plan, a CPT code for suicide safety planning. CMS passed a code for suicide safety planning. That was huge. Unfortunately, it's underutilized, but those are some big wins.
Very good. That's fantastic. Got to keep cheering for that to keep going too.
Absolutely. Every day, all day. Yep.
Looking back, what's the biggest lesson that you've learned from all of this experience?
I think never lose focus and also just stay true to your personal mission. Like, and just keep moving. Like, no matter what happens and, legislation goes a little backwards or, something doesn't get passed or, the number of suicide deaths in adolescence goes up. You have to say, okay, what are we learning? And just stay true and continuing to plug away and do the work.
Given that you're used to solving problems of great magnitude, what are you focused on right now?
I think electronic health records and technology and getting them to adopt the suicide and overdose best practices in prevention. And I would say expanding and adopting an optimization of collaborative care nationally.
Wonderful. Verna, thank you so much for your journey, your perspective, and the real work that you're doing in mental health overdose prevention. What stands out most is your commitment to turning data, leadership, and innovation into real world outcomes that save lives. You have been amazing to talk to today. I think you've been great for our listeners. You've been great for me. And I think this helps us to help you open doors of awareness to help launch everything that you're trying to move forward.
Well, thank you. I appreciate the opportunity, and it's been an absolute pleasure.
Thank you, everyone. That's it for today's episode. Thank you for joining us. And if you got value from today's conversation, please like, share, and don't forget to subscribe. We'll see you next time on Ascend Growth AI Podcast, where we mix smart growth moves with a little AI magic.